Thanks everyone for joining us. My name is Catherine Sherry. I am the Clinical Program Manager with HD Reach. This past, 2 weeks ago, we had our in-person education event. I hope you could have joined us that day. If you weren't there, you probably don't know that we ran out of time during our Ask the Experts panel. So today with me, I have Dr. Mary Edmondson, founder of HD Reach and HD Extraordinaire. And we have a few minutes to catch up with her today to ask her some of the questions we didn't get to. So without further ado, what gives you hope right now?
So I'm going to answer that both as a professional and a human being, because I think what gives people hope, there's not a set answer. It's very different for every single person. Like one person might want to stay alive for somebody that they love. Somebody else might want to stay alive because they want to provide a good example to their children about how to handle Huntington's disease, and they don't want their kids to see ending their own life as the correct solution. Some people have something left they want to do, some bucket list item, some professional accomplishment that they really want to do before they leave this earth. Other people have religious beliefs that suicide is a sin or an affront to their higher power, and for that reason they won't ever consider committing suicide. So those are the ones I've heard, but I'm sure there's many, many, many more reasons that people want to live. And so I think it's real important to articulate that, and it's really important for family members to support that true north goal, whatever it might be. What gives me hope as a provider, as a clinician, and as a psychiatrist, is that there are advances that are being made in Huntington's disease all the time. And I'm not talking about necessarily disease-modifying interventions. I'm talking about interventions that are addressed at quality of life and symptom reduction. So a lot of times, the nugget of hope that people, professionals, advocacy organizations, etc., is dangle this carrot in front of your nose that the hope is really in disease modification. And in other words, stopping or reversing the effects of Huntington's disease so that they basically they might have the gene, but they don't manifest the symptoms of HD. And that is really a laudable goal. It's an important goal. It's one all of us hope for. But it's also not something that will get you out of bed on a bad day. What'll get you out of bed on a bad day is something tangible and right there in the moment. And so I know there are many people that hold on to this idea that there's going to be a treatment in their lifetime and or treatment in their progeny, their children, their grandchildren, that is going to end Huntington's disease. And that's a good hope. But if you have Huntington's disease today and you have active symptoms today, the hope is that those active symptoms can be improved and that your quality of life can be improved now. And the reason that it is more challenging to take a stance on that is because the evidence for using symptomatic treatments that have not gone through a randomized controlled trial, that's not considered high-level evidence. The best evidence is a randomized controlled trial. Deutetrabenazine and tetrabenazine went through highly rigorous scientific experiments that proved that both of those two drugs reduced chorea. And secondary outcomes were, does it improve quality of life? And most doctors should, with some concern, prescribe medications off label, meaning there's not a randomized controlled trial that says that's the best. But there's a lot of evidence gathered from cumulative experience, clinical experience of many, many HD experts. These are people who have had significant experience taking care of Huntington's patients, and through trial and error have found things that they believe consistently work. So, for example, drugs like risperidone or aripiprazole, which are part of a neuroleptic class of drugs, have a theoretical mechanism that makes sense in Huntington's disease. And experts believe that those drugs can both reduce chorea as well as address some psychiatric manifestations of Huntington's disease. So those are in their toolbox. They may not be the first things they go to, but they're in their toolbox. And if drug A doesn't work, there needs to be some other options. And there are options. There are drugs that have broad consensus that can, when used off label, are effective for patients. And there's a caveat to the use of off-label drugs, right? There's never going to be trials of those drugs in Huntington's disease. We're a small population of patients and family members, and there's not going to be an incentive for a drug company to spend millions and millions and millions of dollars on a generic drug. In other words, the drug company has got an indication and they've got enough people taking it that they don't want it they don't have any incentive to increase the use of that drug in a small population. So the odds that anybody is going to look at some of these drugs in a randomized placebo-controlled trial, there might be some, but it's going to be down the road. And it's not, I can't tell you today that risperidone is FDA approved for the treatment of chorea, and yet it's used a lot. So we don't focus very much on symptomatic treatment that the broad experience of HD experts say helps. But I think we're getting better at it. I think that we're broadening the scope of the tools that we have available to patients. And, SSRIs are not FDA approved, but they're used all the time for the treatment of depression and irritability with great results. There are mood stabilizers for people that have irritability and have trouble controlling some of their behaviors associated with irritability. Mood stabilizers work really well. People that are highly agitated and perseverate have responded to antipsychotic or neuroleptic agents like aripiprazole or risperidone or, some of the newer drugs. And so I think that even though we don't have a disease-modifying treatment, and in all honesty, I can't give you false hope that there will be in your lifetime. I hope that every single day. But it's not over until there's a statistically significant positive result in a randomized controlled trial. And that will never be off-label. Those drugs, those interventions will never be off-label. Those will be investigated in highly controlled, very sophisticated clinical trials. And we're all hoping that they might be, positive studies. But I can't promise you there will be. We have to investigate these in human beings for a reason. It's because we don't know the answer. So what we can focus on today to help people with their quality of life are symptomatic treatments who improve quality of life and sort of change the experience of HD in a family so that not only the person with Huntington's is relieved of their symptoms, but their family doesn't have to be secondarily traumatized by those symptoms, particularly people at risk or particularly people who are gene expanded but not yet positive. I think that I don't have any data to back this up, but people that have traumatic childhoods and numbers of adverse experiences and who have poor access to medical and mental health care have more trouble than those people that have more open communication in the family. These things are addressed, and people with HD get better. That's a huge example for children and for young adults, that I might not have the same disease experience as my grandmother. I might not have the same disease experience as my parent. So that's really what gives me hope. And although I don't have data in Huntington's disease, there's really great data in diseases like cystic fibrosis. When I was a medical student, cystic fibrosis was a childhood disease. Now it's an adult disease, because they just simply figured out that treating infection and keeping people's body weight up would help. And it has expanded the lifespan of people with CF by 20 years. So these kinds of interventions that are addressed at simple symptoms or simple factors are the things that I think we can, with all honesty, I can say, I think, change the experience of Huntington's disease and change the experience of people in the family.
So what I'm hearing is that the treatments for the symptoms of HD and are actually quite effective right now, and more effective than they've been for generations past.
Yes.
And connecting people to a treatment team, which supports the whole family, is just going to have a better outcome.
Right.
And reduce trauma in younger generations.
Younger generations. And I want to put it in a specific plug for the treatment of irritability, which is a really scary and difficult problem for families to handle. And the treatment of irritability, in my personal experience, is extremely rewarding. Somebody can come in and everybody in the family is on edge. You can tell they're on edge. The person with Huntington's is, I'm trying to find a word that's not invalidating, but, cranky, edgy, irritable. And irritability, Huntington's disease, is something that happens super fast. It's not provoked, or it's provoked by a really small stimulus. And it's scary to watch, but it's highly treatable. Like within 3 or 4 days, people get better. Like it doesn't take the full month of taking an SSRI before you see results. You don't have to wait an entire month to see if a low dose of an antipsychotic medication is going to take care of that. And so I've seen people come in, just families, and everybody's kind of torn up. And a month later, they come back and they think that I'm a miracle worker because I gave them these drugs, because everybody's at peace. So that's my plug is, I sometimes I think the treatment of depression is a little more difficult. Treatment of anxiety is a little more difficult, but people with HD with irritability, it's like giving them an antibiotic. They're better.
Very effective.
Yeah, very, very effective.
Yeah. Well, it's always a good message. And that is like at the very core of the question I asked, that is hope. A hope for that is giving someone hope is that a medication can be effective to relieve suffering. And that suffering would be the irritability, and that can impact everybody in the family. So,
yeah.
Well, I think just based on time, I think we're going to wind up a little bit here. But Dr. Edmondson, thank you as always. Or was any last parting thoughts that you wanted to leave us with?
Yeah, and that is that I have lots of hope for HD Reach. I really do. An organization going from a founder and sort of everybody sitting around a kitchen table trying to figure out what they want to do, to now being 12 years old.
I think this might be lucky 13. You would know better.
It might be lucky 13, but the fact that it has survived for 13 years means it's a keeper, and it's going to be around for a long time to come for HD families who either live in North Carolina or have family in North Carolina, and that the things that HD Reach does, like this webcast, for example, is accessible to everybody. And I think that HD Reach survived not only that evolution of a social services nonprofit organization, I think it also survived COVID. So I'm real optimistic about it.
Yeah, very lucky.
Yep.
Well, and to further plug HD Reach, for anybody watching this, depending on when you are watching, we are going to continue to have monthly webinars as follow-ups to some of the subject matter. For instance, June 21st, we're doing an interaction with law enforcement. So definitely tune in. But thank you, Dr. Edmondson, for being here today. And we are just so lucky to have you as one of our experts.
Well, I'm lucky to be here.
All right. Well, thanks, everyone. Take care.